tumor. There are some new devices like bipolar probes, which is something that allows you to treat much larger tumors. This actually uses the same generators that you use for other devices. It's just that you use two needles like that. They ablate larger areas in between the needles. So instead of doing the RFA from the center, it actually ablates the space between the needles. And with this patient that had a large ovarian cancer metastasis in the right lobe, we put a central needle here, did an ablation on the medial segment of the mass, and then we removed that needle and put it at the other end and did an ablation on the other segment. This patient is now 3 or 4 years later, and she has a much smaller lesion. You see here those probes is stuck into the needle, into the liver. The complication rate is relatively low, ranges from 0 to 9-point-something% in the literature, and it does increase with when it's associated with tumor resection, when the patients have biliary strictures, had infection before, had some type of biliary surgery, and so forth, so increasing the chances of complication, particularly infection, when you do either chemoembolization or RFA. The RF can be a first-line treatment for HCC, and it has been shown to be very effective. Can you go back and put on the... Yeah, okay, sorry. And you see here the results of this series. At 1 year, survival is 97%, 3 years, 71%, and 5 years, 48% in patients with HCC. Being treated by RFA. If you look at the frequency spectrum that you use when you do RFA and microwave, for example, you see here the whole spectrum of the energy frequencies, and you see microwave is more or less in the center, radio frequency is more or less to the left, a little above television. And our visible light is way to the right of the spectrum here, and X-ray even more to the right. So that's where we are working when we do RFA or microwave ablation. And there are some differences. This is the RFA amplitude of the frequency, and at the bottom you see the microwave. This RFA microwave. So there's much more penetration in the tissue with the microwave. This is the way, the circuit pathway for the RFA. The energy goes back and forth from grounding pads to the needle, and on the microwave it goes back and forth. There are no grounding pads and goes back and forth from the patient to the system and concentrating more the energy. That's the pattern of energy. Can you repeat that for me? I don't think he's there. You see here how the microwave goes along the needle, and it goes beyond the needle as opposed to that's a microwave, and it goes beyond the tip of the needle and before the area of insulation here. So we have a much bigger area, and it does not respect the vessels. It does burn the tissue that's next to vessels. So these are the system for the microwave ablation, and you see here the treatment of some colon metastatic disease was treated with a microwave at 2 levels here and there. This is the PET-CT, and this are the needles in place. And after treatment, you see the PET-CT. There is no more activity in those needles, although there is a new lesion that showed up. It will have to be treated on a separate treatment. So that's what I want to show about that, and thank you for your presence.